Hi, this is Dr. Ashok, Consultant General Surgeon. Today's topic would be shock, not the person getting electrocuted shock. Shock, as such in medical term, means reduced tissue perfusion. Like say a plant requires a lot of water so that it's all moist and green. Even the same way the humans require fluid, and more importantly they require oxygen in every cell of the body. We're all oxygen dependent species, earthlings as such. So shock per se, by definition, it's a syndrome. It's a collection of symptoms and clinical signs because of reduced tissue perfusion. Now there are different categories of shock. You have hypovolemic shock, you have cardiogenic shock, you have extra obstructive cardiogenic shock, you have neurogenic shock, and then you have distributive shock and septic shock. So what do you mean by this hypovolemic shock? Fundamentally, our circulatory system, it has heart, it has arteries, capillaries, veins, and then back again to heart with an additional pulmonary circulation. Okay, eventually, this circulatory system is a closed system in which the heart is the brain of the system. So this heart is a pumping organ, and the fluid gets jetted out of aorta and travels the entire vasculature. Now there is a particular amount of volume present in the entire vasculature. So any depletion of that volume, any hypovolemic state, and then patient is going for a reduced tissue perfusion is called as a hypovolemic shock. This hypovolemic shock broadly you can categorize into two things. One is because of blood loss. Another is because of fluid loss. Blood loss, why does it happen? In case of trauma, road traffic accidents, the patient is pouring liters of blood out of his body. So that is a hypovolemic shock due to trauma. Another set of patients throwing up lot of vomiters, and then another patient passing lot of loose stools. So they're again going to lose gastrointestinal fluids. That again leads to hypovolemic shock. So how do you clinically assess a patient with shock? So before anybody can diagnose a patient going into a decompensated shock, a smart clinician catches things very early. When the patient is slightly going into compensated part, he catches it as soon as possible. So what are the clinical parameters you'll use to identify if the patient is in shock or if he's getting dehydrated slowly? Number one, appearance of the patient. You look at the patient, you look at the patient's eyes, it'll appear very sunken. There should be some amount of retroorbital fat and some fluid to project the eyes, keep the orbits in the proper eye socket. So in dehydrated patients, the eyes appear sunken. Next, the amount of fluid in the body is easily projected on the tongue, the moistness of a tongue. So you ask the patient to pull the tongue out. So the amount of moistness in the tongue, it's another good indication to say whether the patient is dehydrated or he's reasonably hydrated. Next is a skin turgor. Skin has its own collagen, it has its own elasticity. Again, the amount of fluid is an invariable marker to tell the elasticity in the skin. So if the skin recoils slowly after pulling it back, the patient is in dehydration. And when you connect the patient to the pulse oximetry, in the pulse oximetry reading, you're going to see pulse rate, you're going to see how much of the pressure is there. So in the vasculature, if the volume gets lessened, the pressure, ideally the lateral pressure exerted by the moving blood is called as a blood pressure. So the blood pressure eventually drops for these patients. And because of this hypotension, a compensatory adrenergic push will make the patient have tachycardia. So tachycardia and hypotension, these are very two important things which signals you that the patient is dehydrated, he is entering in a state of hypovolemia. And the amount of fluid inside the patient is less, so that his output is again going to be less. You put a Foley catheter and then you mark his amount of urine output. The normal urine output for a 60 kg man should be more than 30 ml. In correct terms, 0.5 to 1 ml per kg per hour should be the amount of urine output for a normal person. If the urine output is reduced, it's called oliguria. It's almost negligible, it's called as anuria. So this again signifies the patient is going into a state of shock. So, and this we saw in a case of in a patient of dehydration. Let's say if the patient is in a trauma, he met with an accident, he's pouring blood. So apart from surgical point of view, apart from arresting the bleed and compressing the area of wounds, so how do you resuscitate these kind of patients? You so for resuscitation, these kind of patients, you push in 1 liter of crystalloids. Any crystalloids would do. Preferably a good plasma expander, a ring lactate or zero 0.9 sodium chloride. After that, if the volume of blood loss is very severe, you immediately send the patient's blood for grouping as well as cross matching. When it matches, you give a balanced blood transfusion. Do not try to blindly push blood alone. Give it with one blood, one cold plasma, and one platelets. 1:1:1 ratio. So blood, the FFP, the fresh frozen plasma, as well as platelets. You give in a balanced thing so that his coagulopathy as well as the other things get corrected. So this is in case of a trauma. So now I hope you have a bit of crisp idea about the hypovolemic shock. Now let's go to the next one, the cardiogenic shock. Now this heart is a beautiful small pumping chamber. So it keeps pumping to jet out blood to enter the vasculature. Now this intrinsic pump stops working. So this is called as a cardiogenic shock. The patient is having enough volume in the vasculature, but the heart as such is not pumping properly. In case of hypovolemic shock, okay, you can relate it to a shampoo bottle. It's getting almost over. You try to press the shampoo, try to take it out. The shampoo bottle is pumping, but the amount coming is very less. But here, the shampoo bottle as such is so hard, despite maximum stuff, and you try to pour, it's not pouring, it's not pumping. So that's when I try to relate it. So this is the intrinsic pump failure happening in the heart. This is called as cardiogenic shock. So what causes intrinsic pump failure? A myocardial infarction, an ischemia to the heart, a myocarditis. The heart is getting infected, the infective endocarditis. And sometimes the heart is trying to pump and the valves are obstructing, some stenosed valve or some papillae, the papillary muscles, they get ruptured here and there. So all these things, along with some arrhythmia, everything in the heart is not pumping effectively. Small, fast pumps, arrhythmia, flutters, all these things lead to the cardiogenic shock. So in case of cardiogenic shock, there are some other vital markers you have to measure. The central venous pressure, which is a surrogate to say how much amount of preload is there in the body. Heart is not pumping to the arteries. Rather, blood is getting stagnated in the veins. So a central venous pressure marks excellently. And one more thing about cardiogenic shock is the extracardiogenic shock. Here the intrinsic heart pump fail. In extracardiogenic shock, intrinsically the heart is ready to pump, but outside the heart, that is the mediastinum, between the lung region, there could be some tumor that is obstructing the heart, not letting the heart expand. So those tumors could be a reason, a pulmonary embolism, the lung issue, or an air embolism. All these things, some tension pneumothorax because of a trauma, all these things won't let the heart expand or contract. This is an extra cause of extracardiogenic shock. So some pericardial effusion, all these things causes. So here you have to watch out for a Beck's triad. So Beck's triad is simple as such. There is not enough blood pressure, it's not pumping, no enough pressure, and then hypotension results, and then you try to auscultate for heart sounds, and then it's filled with fluid or other things. The heart sounds are not proper, it's completely muffled. And one more thing, all the fluid is there in the vasculature compartment, so the JVP will be raised in this patients. Unless it strikes you that you have to check for Beck's triad, you won't be able to do that. And again, all these three components of Beck's triad doesn't mean it has to appear in the patient. So fundamentally, you have to note each and every clinical thing to see. So in cardiogenic shock, do not try to pump in more fluids. The patient is having fluids, but there is pumping failure. So identify the cause of cardiogenic shock and try to rectify that. So that's with cardiogenic shock. Let's go to the neurogenic shock. Now this neurogenic shock is little interesting. Why? Because the vasculatures maintain its tone, the peripheral vascular resistance. The vessels need to have a proper tone so that it conducts fluids inside that. Now this conductivity of a vessel, everything is managed by the nervous system as such. Now the patient met with a road traffic accident and he's having some spinal cord injury. Preferably it should be cervical, not preferably, it should have been cervical or upper thoracic levels, precisely T4 above. So this part controls the sympathetic outflow. So if this is affected, the patient's vasculature tone is it's going to go into a flaccid state, and then he's gonna go into hypotension. He's eventually going to go into a shock. So this is called as a neurogenic shock. So you have to watch out for a case of road traffic accidents. You have to check for cervical spine injury or upper thoracic vertebra injury. The patient will eventually have quadriparesis. That's with neurogenic shock. Next, you have septic shock. Now this septic shock is little critical, and hopefully none of your patients go into a state of septic shock. Now any SIRS is systemic inflammatory response syndrome. If you have a particular inflammation in one part of the body and the entire body is responding to that, that is SIRS. Now with this SIRS, you have an identified source of any sepsis inside your body. That is called as septic shock. This is by definition. In layman terms, what is the problem with sepsis is, we are earthlings, we require fluid and oxygen at the end of the day, at the beginning of the day, in the middle of the day. So in sepsis, what happens is tissue death starts happening. At cellular level, every irreversible process happens, and then the oxygen which we require does not get utilized properly. So no matter, even if you sedate the patient, you intubate the patient, you give high flow oxygen to the patient, the cell loses its integrity to utilize an oxygen in case of sepsis, if the patient is in severe sepsis. So how do you identify, the patient is in severe sepsis? Septic shock, eventually all your aerobic metabolism shifts to anaerobic metabolism. So the normal lactate, which is supposed to be 1, it shoots up more than 1. And even the base deficit keeps getting increased. 2 to -2 base deficits are fine. So, but then -2, -4, -6, -8, more than -10, it's a massive base deficit that is required to, that tells you how severe the patient is in septic shock. So it is very tough for a septic shock patient to be revived. And in previous video, we saw about how colloids, albumin, dextran, these macromolecules enter the vasculature which has pores but does not let the pores to leak out all the fluid. It helps to improve. So these things help. So this is the case of a septic shock. Now the treatment part, I'll just touch. I do not want to go depth into the treatment. Number 1, you require lots of fluid to resuscitate the patient. And then you have to make sure the endpoint resuscitation comes back to normal. The tachycardia should settle, blood pressure should be adequate, and urine output should be adequate. The lactate should come back to normal, and the base deficit should come back to normal. All these things, you should see it as a whole. You should not stick to just one particular criteria. So these are the things. And some inotropes, low dose dopamine. Inotropes make your heart pump, and dopamine just keeps your blood pressure level up. Some vasopressins, and sometimes ACTH resistance occurs, so you give steroids. So all these medications eventually help patients come out of shock. So this is shock in a nutshell. I'll see you in another video. Thank you.